So as usual, before I get started, I just like to ask people to type into the chat. Let me know where you're from. I like to see where students are from. Hello. I like to see where everybody is from just so I can get a feel for the room. Okay, New York, Kenya. Listen, I'll be there one day, someday. It's gonna happen. Ghana, I love it. I'm gonna be there too. Cali, okay. Awesome. Virginia, Canada, love it, love it, love it. So for those of you who are joining for the first time, Nepal, wow. Those of you who are joining for the first time, um, I do like students to be very interactive. Don't be afraid to unmute yourself, ask questions, insert commentary. If you need me to repeat something, please, again, do not hesitate to unmute yourself and go ahead and ask me to repeat. I do throughout the presentation ask little questions here and there just to see if you guys are following or also to get your mind going a little bit. Saudi Arabia, awesome. Oh, wow. In Florida. So I'm in Miami. I see someone here from Florida. I am in Miami myself. So it's a little after 9 here. So let's go ahead and get started. I'm going to share my screen. And again, we are covering mental health disorders part 2. So this is an extenuation from my presentation from last week. Actually, let me make sure that I cut on the sound before I share to make sure we pick up sound. Okay, so you should be able to see the screen, mental health disorder. So these are the topics that we will be covering. Post-traumatic stress disorder, also PTSD. So if you hear me say PTSD, that's what we're referring to. Phobias, which means to have a fear of something. And lastly, obsessive compulsive disorder, also known as OCD. So I'm going to get into slideshow view. Again, please be very, very interactive, ask questions, go ahead and jump in whenever you want to add commentary. I love students that are interactive because, of course, that makes the webinar more fun and it helps me to understand what you guys know or don't know. So these are the objectives for tonight's webinar. So you're going to be able to not only define these different conditions, you're going to understand the behaviors that are associated with these conditions. It's very important that you understand the behaviors. Remember, when it comes to mental health conditions, these are not physical conditions. So it's not like you can measure a lot to help you understand what's going on with your client. A lot of this is observation. A lot of this is based off what the client reports that they are feeling or seeing. So it's very, very important that you're able to distinguish certain behaviors that you may see based on the disorder that the client may have. We're going to talk about treatment modalities. It's not always medication that we use when it comes to managing clients with mental health disorders. We also rely on a lot of therapeutic type of interventions. So different types of therapies, and there's different types that we use based on the client's actual diagnoses. And you also want to be able to evaluate the effectiveness. That is also on the NCLEX that a lot of students don't think about. You don't always just have to know, what am I supposed to do? You also need to know, how do I know if what I'm doing is effective, which means I continue to do it, or is it not working? That means I need to reevaluate or revamp my plan of care. Okay. So first up, we are covering post-traumatic stress disorder, also known as PTSD. So first things first, what is post-traumatic stress disorder, PTSD? So this is a type of condition where you either experienced or you personally witness a traumatic event. It's not always something that happened to you per se. You could have been a witness to something that was truly traumatic. For example, you saw someone get hit by a car, okay? Or worst case scenario, you saw someone become unalived. Or let's say you were in a situation where something very traumatic happened to you. You were in a very traumatic car accident. Okay. A lot of people who come back from the military have a lot of PTSD from the things that they've seen, the things that they've experienced. I've had clients that had PTSD from the way that they were brought up. Okay. Sometimes parents can be strict. Sometimes they have rules. Sometimes that, their household is ran a type of way, and it can be traumatic for a child growing up into adulthood, and they never really got over what happened during their childhood. So that for them could be post-traumatic stress. Witnessing a family member pass away, after a long battle with an illness, those are all examples of things that can be traumatic to the individual. For the person themselves, Okay, it could be emotional distress, it could be physical distress. For example, if you were in a traumatic car accident, it left you disfigured, it left you disabled. So it's a constant reminder of whatever the experience that you had, or it is a mental 1,000-yard stare. That's interesting, Andres. 1,000-yard stare. What does that mean, if you don't mind sharing? Because I've never heard of that. If you're talking, you're muted, or you can type it into the chat. Oh, the life, the war. And you know what, unfortunately, I have not experienced the military, but I do have colleagues that have worked in the VA hospitals that do treat veterans of war. And there's a lot of PTSD, and a lot of it travels with them, even years after they have retired or left. So again, for the individual, okay, it's not just a physical traumatic event. It could be emotional. It could be mental. They view the experience possibly as life-threatening. Okay, and it's very, very important for these individuals that we help them work through these emotions, these feelings, because again, this is something that travels with them for the rest of their lives. The actual trauma or the stress, it causes a lot of disruption in the client's life. The disruption can be so severe that it interferes with activities of daily living. And if one thing you're going to learn how to do is, a lot of these mental health conditions, they are connected in the way that they disrupt daily living activities. Things that you would expect a person to be able to do with no problem, they have trouble doing that. And you see that a lot with mental health disorders. Also, this is something that's categorized as anxiety. So if you guys were with me last week, we went over different types of anxieties, panic, generalized anxiety disorder. So the conditions that we're covering tonight, they are an extenuation of anxiety. So if you wanted to categorize these into a broader term, this is considered a form of anxiety. Okay. So let's talk about your signs and your symptoms. Now, do keep in mind, when it comes to mental health disorders, everyone is not going to manifest signs and symptoms the same way. There are signs and symptoms we expect to see. There may be some signs and symptoms we do not expect to see, but there are general manifestations or signs and symptoms that a lot of people with post-traumatic stress disorder share, and those are nightmares. Okay. Nightmares is when, the dreams that you have are reoccurring, and they're always, centered around the event that caused you the trauma. Again, whether you experienced it yourself or you witnessed it. Okay. And with this traumatic experience, this is something that's going to keep happening continuously. And it may even interfere with your ability to sleep. So do not be surprised if you have a client with post-traumatic distress syndrome that is complaining of insomnia. They're having trouble sleeping, or they're very fatigued. For a lot of people, after they've been through something traumatic, they become what we describe numb or void inside. It's almost as if their feelings have left them. Okay. And for us who haven't experienced the trauma, we may not be able to understand why the person is so cold, to put it in parentheses. But the person is, it's like it took so much out of them, they just have nothing left. So it may not look like they care about certain things. However, they may care, they just don't know how to express it, or they're very hard with feeling certain things. Negative thoughts. Okay, that is also something that we see. Somebody is not muted. Okay, Siri. Siri loves picking up when I talk. Um, Emotional numbness, again, that is something that can be mistaken for a person not caring. But again, it's not necessarily that. It's just that the person has a hard time when it comes to their emotions. Hypervigilance. So this is something where a person is very, very, what's the word, aware or super aware of their surroundings. Their alertness is heightened. Okay. They're always on the lookout for certain things, especially if this was an event that they experienced personally. Okay. I'll give you a perfect example. I had a client that was assaulted, and when she finally was able to, to get back outside and go outside and walk or travel certain places, she said she was always looking over her shoulder because she might not know if somebody is coming up behind her or if they may attack her again. So she was very hyper vigilant. It was always something, and everybody was suspicious to her. And hypervigilance can also cause you to see things that are not there because you're so super alert. Any little thing can trigger you, and it can take you back to that time period of your trauma. Reduce interest. Now, this is a big one. Things that a person may have normally been excited to do, interested in, they don't seem to have that same interest or that same love anymore. This could be anything, and this could be something that they really, really, truly enjoy doing. If the trauma is connected to that activity that the person once previously loved to do, definitely expect that there may be a lack of interest in them doing it again. Or if they do want to maybe get back into the activity, it's really hard for them to take that step because, again, they're always reminded of their trauma. Feelings of hopelessness. Okay, always with the despair, always, and that ties into the negative feelings, the negative thoughts. They have feelings of, just worrisome, just negativity. If you imagine like a cloud always hanging over, something like that. Okay, flashbacks. They're always having flashbacks of the event. It's almost like they're reliving it or they're re-experiencing it. Okay, avoidance. So if the person has identified triggers or something that links to their trauma, they will try to avoid it. Now, that's not always necessarily a bad thing because we teach people if there's something that triggers, try to avoid it. However, with the triggers, if they are avoiding something in general, it could be something that's not necessarily related to the trauma, and that avoidance is causing them to maybe miss out on certain things that they normally would enjoy. Or again, it doesn't necessarily have anything to do with their trauma. So again, affecting activities of daily living. We talked about the insomnia, the sleep issues that could be tied into the nightmares that the clients has, and then the difficulty concentrating. Okay, it's very hard for them to focus depending on the severity of the trauma, especially if they are surrounded by triggers. So, managing post traumatic stress disorder takes on a multifocal concept. Okay, we don't focus on one particular thing because these symptoms are so wide variety, so wide range, and we know that client manifests things differently. When it comes to putting together a plan of care, we want to keep in mind what individual needs does this particular client have based on the symptoms that they have and of course, based on the trauma that they experience. Any questions when it comes to signs and symptoms of PTSD? Okay, moving on. So let's talk about the types of post-traumatic stress disorder, and there are different types. Okay, just like you have multiple types of anxiety, there's multiple types of post-traumatic stress disorder. So first is a normal stress response. Now, last week when we went over anxiety, we talked about anxiety is normal. Okay, there are normal stress responses that we expect people to have. You are human, that is a natural emotion. If you are involved in something that may be causing you a little bit of distress, it is normal to have anxiety. It is normal to have a stress related response. Again, think about how you guys felt whenever you sat down to take a nursing test. Okay, it don't matter how much you study, you could have studied for a whole month before the test, never really feel like you're quite ready, and that anxiety is there, the nerves. Okay, you may experience some nerves when you sit down to take your NCLEX. That is normal, that is expected. However, it does not interfere with your daily activities. Now, even though that normal stress response is expected, knowing that the person may have experienced something traumatic, you just want to keep an eye on it just to make sure that it doesn't evolve or get worse than what it currently is. The next type of PTSD that you have is called acute stress disorder. So this is a type of PTSD where you have memories of the traumatic event, you're hyper aroused, so hyper vigilant as well, and you may experience some avoidance. Again, whatever triggers you related to that experience, you may try to avoid those things. Now, when it becomes acute, it's because of the time frame. So this is something that recently may have happened to you. As a matter of fact, within 1 month. So that's not a very long time at all. As a matter of fact, you may not even know the client has experienced something traumatic because what if they're not really ready to talk about it just at that moment? So for them personally, they're experiencing the trauma. However, you as the caregiver, you may not even notice because again, they may not be expressing it or they may not even be talking about it. But again, it happened within a month of the client experiencing these particular symptoms. Then you have what is called uncomplicated PTSD. So this is your typical post-traumatic stress disorder symptoms that we talked about on the prior slide. However, there's not any other additional manifestations that you may tend to see. When I say additional manifestations, I'm talking about, signs and symptoms of maybe there's another disorder there somewhere, such as depression. Okay, maybe bipolar conditions, personality related disorders. So when you have uncomplicated PTSD, it is just PTSD by itself. No other manifestations to possibly suggest that the client has another disorder that we haven't quite caught or diagnosed. And then you have complex PTSD. So this is prolonged trauma exposure. Okay, your symptoms are not just PTSD related, but they then become a little bit more severe. For example, the signs of depression now start to set in. Okay, sometimes when people experience something traumatic, they develop what we call a split personality. It's almost like they may try to disassociate or disconnect themselves from reality to help them get over the trauma. And for a lot of people, this is what we call a protective mechanism. It's not an effective or a positive coping mechanism, but it's for that person, it is a coping strategy. So when you have complex PTSD, not only do you have the general manifestations, but again, you're showing signs and symptoms of more complex or additional mental health disorders. And lastly, comorbid PTSD. Okay, so this is almost the same of complex PTSD, except that now comorbid is after that what month? Okay, that's a great question. So honestly, it's hard to put a time frame on it. Anything outside of a month, however, it's probably a little bit longer than that. But remember, keep in mind, the person could have had these manifestations for a while. It just wasn't caught or diagnosed. And honestly, you only have the patient's word for how long they've been experiencing whatever they've been experiencing. So a lot of times with mental health disorders, all we got is what the patient tells us as far as what they're feeling. With comorbid PTSD, now we have a definitive diagnosis of another mental health disorder. See, with complex PTSD, a definitive diagnosis hasn't been made yet. The client shows the symptoms, it just hasn't been officially diagnosed or put in the medical records. With comorbid, there's clear diagnoses, the medical health care provider, assess the client, and of course, they were officially diagnosed. So these are your different types of PTSD. Any questions with these? I like to keep track of the time. So if you see me looking down a lot, I'm looking at my phone, checking the time. So now let's get into treating post-traumatic stress disorder. So again, it's important to make sure you understand not everybody who has traumatic experiences develop PTSD. Okay, that is a misconception. If you've been through something traumatic, you're experiencing the aftermath of it. Sometimes it takes a while for people to get over things. For example, a loved one passed away, a pet passed away. You've been through again a traumatic experience, such as a very bad car accident. Sometimes that process of healing does take time. That does not necessarily mean you have post-traumatic stress disorder. Remember, you have to have those other manifestations like the avoidance, the hypervigilance, the nightmares, the insomnia. That is when it starts to be possibly post-traumatic stress disorder. Just having a grieving heart or just not being in the mood because you just experienced a loss, that is not necessarily PTSD. Okay. And also, everybody that does have post traumatic stress, they don't always need to be followed by a healthcare professional. Only if it starts to interfere with activities of daily living. I can say that I went through something traumatic and I'm still dealing with the aftermath. However, I am functionable. I'm able to go to work every day. It is not interfering with my life. It's not interfering with my relationships, my ability to take care of my son. None of that is happening. Therefore, I'm not at the point where I need to see a healthcare professional about treatment. So that is important because there's a misconception that one always goes with the other. So let's talk about your therapeutic ways to manage PTSD. So with mental health disorders, a lot of times you're going to see not everything requires medication. Okay, it is definitely symptom based. So cognitive processing, that is where we just try to retrain the client's thoughts. When you say cognition or cognitive, again, how the client thinks. A lot of times, if you change the outlook or the thought processes that's related to the trauma, the client's condition can improve. So we try to associate positive with the trauma. If there's any, we try to find it. Okay. A lot of times people have trauma because of guilt when it comes to a situation. There's something called survivor's remorse. And for a lot of people, if they've been through a traumatic accident and they survived and somebody else didn't, they may experience trauma behind that. So again, we try to retrain the client's thought processes to help them improve the traumatic stress disorder. Prolonged exposure therapy. For a lot of post-traumatic stress situations, this is a type of therapy that we like to see if clients will benefit from. Okay. We're also going to see this again. We go over phobias. So this is something where you're going to little by little keep exposing the client to this traumatic experience or something that relates to the traumatic experience. The goal is to try to decrease the reaction or decrease when it's a trigger, decrease the response. It's almost like how we help clients get over allergies. Sometimes that is done where they will little by little keep exposing, and then the reaction is less severe each time until there is no reaction at all. Depending on what is causing the trauma, this is something that is very easy to do. Now, of course, if this is a traumatic experience, like something from childhood, then that may be a little harder to use this type of therapy from because this is something that happened so long ago. But if this is something that was recent, something that has a physical attachment to the trauma, then we can possibly do this type of therapy with the client. Trauma focused cognitive behavior therapy. Again, this is solely based on the trauma. So whatever interventions we employ with the client comes directly from the traumatic experience and nothing else. Eye movement desensitization. So this is something that is fairly new. We don't see it a lot, but research has shown that it is effective. So what we're doing is we're reprogramming memories. That is actually something that we try to do, and it is done through sleep. Okay. If you guys are familiar with something called REM, rapid eye movement, we tend to have the rapid eye movement when we're dreaming. Okay, that is when it is connected to that. So what we try to do is we try to put clients into a stage of REM, and then we try to recreate memories based on the traumatic experience. Okay. Again, this is not something we see typically used. However, research has shown that it does work. It takes an ability to be able to disassociate with the actual trauma and try to associate with something a little less traumatic or a little less negative. Okay. This alone probably will not be enough to manage PTSD in some clients. But again, the goal is to try to reprogram or rechange the memories. So there is someone that is not muted. Give me a second. Just want to see. Remember, you guys, I have no problem with you unmuting yourself if you want to add to the conversation or ask a question. It's just sometimes when you have the background conversation, it picks up in the recording. And I want to make sure nobody is saying something that they don't want us to hear, because that does happen sometimes. Okay. So group therapy. Now, again, that may help the client confront, they're not alone or they're around other people who may experience the same thing. Sometimes it's powers in numbers. Sometimes it's not enough for the client to try to recover from the traumatic event by themselves. And this helps a lot. We do this a lot with teens. Okay. When we are managing teens with mental health disorders in that stage of development, they connect more with friends or people that they relate to. So for a lot of times, it's important to possibly surround a client with people that can relate. Could you explain REM? Okay, no problem. We can go back to that. So REM stands for rapid eye movement. Okay. That is a stage of sleep. When you sleep, your body kind of drifts into levels of sleep. So it's not like you close your eyes and then boom, you sleep and you dreaming. It's like a process of getting to that deep sleep stage. And what scientists have discovered is that when a person is doing what we call rapid eye movement, so basically the eyes are kind of darting all over the place. When they are in that stage of sleep, that is associated with dreams, or you're in a deep sleep. Okay, so it is at that moment that scientists or people who are treating individuals with post-traumatic stress disorder, that is when they kind of try to insert new memories. And this is not always done while they're asleep. Okay, they may start the process while the client is awake, try to plant an idea in the client's head, because a lot of times trauma that happened so long ago, you may not be able to remember it 100%, or you have bits and pieces of it. So what they try to do is they try to put together a picture, but something that was different from what may have actually occurred. So that's what REM is. It's like when you're in a stage of deep sleep. Okay. You're welcome. No problem. And then again, it's the group therapy. Again, maybe it's just helpful to be around other people that you can relate to. Hearing somebody else's experience might help you. So group therapy is definitely a good way to help patients or clients manage PTSD. And then we get into the medications. Again, this is not one size fit all. Sometimes it takes a little bit of time, to see if medications will work. Because remember, with a lot of mental health conditions, medications take time to come into effect. And that's one of the important things. We talked about that last week. When you're providing education to clients, when it comes to certain medications, listen, you need to stay compliant. Okay. This is not an overnight quick fix. It may take a couple of weeks for you to feel the effects of these medications. But in the meantime, just stick to the plan of care and eventually you will start to see some progress. So that's what happens with these particular medications, antidepressants. Okay. The goal is to improve the mood. The goal is to, do away with the negativity and try to get the client, a little bit more upbeat, a little bit more positive. What is the difference between cognitive? There is none. Nika, that's their exact same thing. Cognitive just means the brain, thought processes, cognitive behavior therapy. You're just pretty much retraining the person's actions. I give you a perfect scenario. Let's say you have a child that has ADHD, right? And we all heard of ADHD. That is a hyperactivity disorder. And, there's a lot of behaviors associated with ADHD. So, what we try to do with cognitive behavior therapy is we try to put emphasis on the positive, a lot of emphasis on the good stuff and less emphasis on the bad stuff. We're not ignoring the bad. We're not ignoring the negative. We're just not emphasizing it, because you have to pay attention to it. So you can't just forget that it's there, especially if the person is in danger of harming themselves or harming other people. So what you do is, if you put so much emphasis on the positive behavior, the goal is that the person will eventually realize, I need to keep doing this, because when I do this, I get rewarded, or when I do this, I feel better. So it's almost like just reprogramming how the person behaves. And that's all. That cognitive is just, how the person thinks. Cognitive behavior therapy, reprogramming or retraining how the person behaves. That's all that. It's pretty much the same thing. Blood pressure medication. So not all blood pressure medication, okay, first of all, but this particular blood pressure medication that I put there in parentheses, while they were discovering how this medication treats blood pressure, one of the things that they noticed is that people who were having nightmares, particularly post-traumatic stress disorder related nightmares, they were noticing that the nightmares weren't as severe, or they were decreasing altogether. And when the nightmares started to decrease, the individual was getting better sleep. So what they started doing is, with some post-traumatic stress disorder therapy options, they will incorporate this medication. Again, it is not to manage the blood pressure. It is to help manage the nightmares, which can improve sleep. So, of course, the education here, and this is the type of questions that you are going to see on the NCLEX. What is important to teach clients about this particular medication? Since this is a medication that treats hypertension, the client needs to keep track of their blood pressure. Okay. Because if you have, let's say, normal blood pressure ranges and you start taking this medication, you can become hypotensive. So that means you need to associate signs and symptoms with hypotension that you need to teach the client. So lightheadedness, dizziness, fainting. Okay, that is the education that comes with this medication. And again, that's what you see on the NCLEX. What is important for me to teach this client about the medications that they are taking? If you are taking this particular medication to manage post-traumatic stress disorder symptoms, make sure you monitor your blood pressure. This medication can lower your blood pressure. You can become hypotensive. The symptoms you need to monitor yourself for: dizziness, lightheadedness, fainting. Okay. You may even suggest, okay, go to the store, get one of those little handheld, small type monitors. They could just check their blood pressure throughout the day. Or if you're feeling lightheaded, dizzy, go ahead and check your blood pressure and see what the numbers are. So those are the type of things that you see on the NCLEX. Okay. Then you have your antipsychotics. If you have a client with post-traumatic stress and they are having hallucinations, that does happen. So this is what we call either complex or comorbid. Okay. If the client is having the hallucinations and they haven't diagnosed them, let's say something like schizophrenia, then it is just complex post-traumatic stress. If they do have an official diagnosis, then it becomes comorbid. Either way, when it comes to the antipsychotics, the goal again to reduce the hallucinations or the negative behavior. Again, make sure clients understand they need to stay compliant with the routine care plan, because if they stop taking the medication, one, they're never going to see an improvement in their mood. And two, what do we know about certain medications? What do we teach clients about certain medications? What should they not do when it comes to certain medications?
Stop
You
it
can
abruptly.
stop it abruptly. Yes, ma'am. I'm not sure who that is, but thank you. You should not stop certain medications abruptly. Okay. So again, when it comes to education, those are the little things you got to keep in mind that you may see on the NCLEX. And then you have acupuncture. Now, acupuncture might not be something that is traditional, let's say in the United States. However, it is a part of what we call traditional or non-traditional, I'm sorry, alternative complementary medication therapy. Sometimes we incorporate non-conventional things. Okay, especially if the client is into them. And acupuncture is a form of medicine. It is more a form of Chinese traditional medicine, but we do incorporate acupuncture in a lot of mental health treatments. All you're simply doing is putting needles, very fine needles, in certain, pressure areas of the body. The goal is to relax the client. The goal to release the energy that may be weighing a client down. Hopefully the mood is improved. The client may need to have more than one session of acupuncture because remember, treating mental health disorder is not an overnight quick fix. So it is very possible that a client may need more than one therapy session. They may need a conjunction of therapy sessions, including medication mixes. But again, we try to figure out what works for the client individually, and we select those interventions based on the client's immediate needs. Any questions with treating post-traumatic stress disorder, both therapeutic therapies as well as the medications that we give these clients? So, nursing management, most important thing.
Question. Oh,
So, nursing management, important for you to know if you are taking care of a client that does have post-traumatic stress disorder. So, as you can see in bold, I have prioritized safety. A lot of times when it comes to the traumatic experience, the reaction can possibly put the client in harm's way or someone else in harm's way. You always want to establish a safe environment. Okay. And you're going to see this for a lot of mental health conditions. Safety is always a top priority. Okay. Whether that means you remove the client from the environment and put them somewhere else. Okay. Or the client may feel safer at home. However, the case is, the client needs to be safe and they need to be made assured that they are safe. Therapeutic communication. Now, if you guys remember last week, we talked about updates on the NCLEX. Okay. And if you guys are joining me for the first time, we talked about the latest update that the NCLEX did. So, what the NCLEX does is it will look at the data from the past couple of years and they look for areas that students are not performing well in. And the latest NCLEX update, which took place, I believe, around April 2023, I believe that was the year, they saw that therapeutic communication was not a strong point. And there are a lot of therapeutic communication questions when it comes to mental health. You know, how should the nurse respond? Or what is an appropriate response? What is a therapeutic response? And with a lot of mental health disorders, a lot of the treatment focuses on psychotherapy, which is talking. So when a client makes a certain statement, how do I appropriately or therapeutically respond? That is very important in mental health because remember, one, you don't want to put emphasis on the negative. You always want to validate the client as far as their feelings. You're not crazy. I don't like that word, but they use that word a lot in mental health. You want to validate the client's feelings. They're not crazy. They have a mental health disorder. However, they are there to have, get help. We're there to work with you. So you want to maintain therapeutic communication. Okay. What is the most appropriate response to something that a client says? Okay. Relaxation. You always want to teach the client how to relax. Let's say deep breathing. That's one of the best things that you can do if you're having a moment where you feel, you're getting stressed out or you feel your anxiety or something taking over. Telling the client to take a breather in through the nose, out through the mouth. Breathe in slow through the nose, breathe out slow through the mouth, pursed lip breathing. What if it's, listening to music that relaxes the client or coloring, reading, sleeping, take a nap. When you feel yourself getting worked up, just lay down and try to take a nap, meditate. Okay, those are things that we teach clients when it comes to relaxation. And remember, everybody is different. So you may have to do a little bit of searching to see what relaxes the client. I had one client, they would go to the gun range. Listen, whatever works as long as it's done at the gun range and nowhere else. If that's what it takes to help you relax, then that's what it is. He said it helps him relieve stress. As long as it's in a safe, controlled environment, hey, knock yourself out. We've had some clients say that doing volunteer work relaxes them. So it's not always, the conventional, take a bubble bath, drink some wine, read a book, in through the nose, out through the mouth. Sometimes it's something physical that relaxes the client. Evaluate the support systems. That is also important. If you have a client that is experiencing a mental health disorder, especially post-traumatic stress disorder, what is the support system looking like? Who's in the home? Who has immediate access to the client? When the client leaves the healthcare facility and they go back home, if they're starting to spiral, if the behaviors are starting to appear, they're becoming overwhelmed, they're triggered, who is going to be there to help recenter the client? Who can we teach to look for these certain signs and symptoms so that maybe the client needs to be brought in because they are becoming triggered, and who knows the response you're going to see. When it comes to recovering from a mental health disorder, it is very important that the client has a strong support system. Okay. And lastly, make sure you do those medication orders as they are in place. Remember, compliance tends to be one of the hardest things for some people to stay on top of. A lot of times we see that you're not getting better or your condition is not improving because you're not taking your medications like you are supposed to. So, for example, and I'll give you a perfect example, if you are managing, let's say, hypertension, and a client comes back after 3 months and we see not only is your blood pressure not lowered, but it's actually gotten worse. First thing I want to ask, are you following your medication orders? Are you compliant with the medication orders? A lot of times, again, that's why the client is not improving. They're not taking their medications like they're supposed to. And this is something big in mental health because, again, it can take a while for the client to feel the effects. So they may get discouraged and say, this is not working. I don't feel anything. I'm still this, I'm still that. And then they're not taking the medication. So you have to emphasize that you need to take medications as ordered. Okay. I need to be on time with the medications. You need to be on time with the medications as well. And again, it may take a couple of weeks for you to feel the effects, especially antidepressants. Any questions when it comes to post-traumatic stress disorder? So we went over what the condition is, so a general overview. We talked about the manifestations. We talked about how we treat it, how we manage it. And then we also went over nursing responsibilities or nursing management. What's important, including prioritizing safety as your number one option. Any questions? Okay, you guys, let's check the time. Okay, good time. It is 9:45. Okay, let's take a 10-minute breather. So I'll give you guys a quick break and then we come back and we will get into phobia. So again, you guys, 10-minute break. It is 9:45. Okay, everyone, welcome back. We are now going to get into phobias. So, piece of advice for NCLEX testing. Okay, remember, and I said this last week, and I say this all the time when I'm lecturing students or tutoring students. You're not going to know everything. Don't stress yourself out trying to learn or read everything. A lot of times, if you're able to critically think or break stuff down, you have a better chance of getting questions correct. And that's something that's going to help you on the NCLEX. When it comes to certain words, they have alternative meanings. And if you learn your suffixes and your prefixes, especially when it comes to medical terms or medical diagnoses, that gets you at least a little bit of the way there to answering the question. So the word phobia, okay, who knows what the word phobia means? So if you saw a word,
Fear.
the fear, exactly. Look at y'all. Fear of something. Okay. Now you just need to know what their fear is, but you are at least halfway there. So if you see the ending phobia, you know your client has a fear of something. Now, if you read the rest of the question, you may be able to kind of piece together what their fear is, but there are some phobias that we're very familiar with. For example, claustrophobia. So if you hear the term claustrophobia, what do you guys think that means? Because that's a very common fear that people have. Claustrophobia. Who knows what that means?
Fear
Claustro.
of fear of being in a particular space.
That is exactly what claustrophobia is.
Fear of being in a confined space.
A confined type space. Perfect. So a lot of phobias we are familiar with, but then listen, there is a name for everything. If you guys ever have the opportunity to, as a matter of fact, I'm gonna probably look for a link for that. The different types of phobias. They're literally fears for everything. So what exactly is a phobia? So it is a type of an anxiety disorder, and it is typically defined as a person having an intense, irrational fear of a specific object, a situation, or an event that causes a lot of distress and it interferes with daily life activities. So, again, the key term is irrational and intense. Okay, so that indicates it is not abnormal to fear things. Okay, a lot of us are scared or fearful of certain things. However, the fear that we have is warranted. It makes sense. When you're talking about a phobia, the response is very exaggerated. And also, whatever they are afraid of may not pose a risk to harming the client at all. They just have an extreme irrational fear response to that object. I'll give you guys a perfect example. I do have some fears. However, I'm not diagnosed technically as having a phobia. So one of the things that I don't like lightning. And if y'all can imagine, I live in Miami. So when it's hurricane season and these storms passing through here, y'all can only imagine what I'm going through over here. I don't like lightning. I'm scared of lightning. When it's lightning outside, I am still. If I'm driving and it's lightning, I will pull over and I will get still. Now, I'm still able to function, okay? But I do have a fear of lightning. So for me, it's not a phobia. Another fear that I have, I don't like driving over water. And for me, it's not like I've ever been in a situation where something happened. I just don't like driving over water. So if it's a bridge, listen, my heart starts beating a little bit. But again, I can still drive. I can still make my way over that bridge. I just don't like when I'm doing it. So for those of you who are familiar with Florida, okay, and driving to Key West, that's something I have never done because that is a 7-mile bridge over water. I have not did that just yet. Now, if somebody else driving over water, I'm relaxed. But if it's me, not. However, for me, it is not a phobia because it's not that it's an irrational fear. You know, there is danger when you're driving over water. There is danger when there is lightning. So it's not that it is an unfounded fear. Plus, it does not interfere again with my daily activities. But for people with a specific type of a phobia, it is an exaggerated response that a fear interferes with their daily life. The fear that this person feels is persistent. it doesn't ever go away. For me, as long as it's not raining and lightning, I'm fine. As long as I'm driving over a road and I'm not driving over water, I'm fine. But for these individuals, this is something persistent. It's like they don't even have to be around what is causing them to have that extreme fear reaction, but just the thought of it alone can invoke those feelings of fear, and they feel an impending doom or something like that. So these are just certain types of phobias that we are, familiar with, or we've heard of at least once. Agoraphobia. So this is a common phobia for a lot of people, fear of open or crowded spaces. Now, for some people, it's just being out in the open. Okay. So going to the mall, that might be a problem for this person. Going to a parade might be a problem for this person. Any place where there is, a good number of people gathered, this person will have a fear. Going to the beach, something as simple as that. That is something that they may have trouble with because, again, it is an open space with a lot of people in it. And then on the flip side, you have claustrophobia, which you guys have already defined, a fear of confined spaces. A lot of time with claustrophobia, it's not just the confined space, but fear that I can't get out of this confined space. So it's like the fear of feeling trapped. So for a lot of people, being on an elevator can cause them to have claustrophobia because an elevator is confined. And what if I get stuck? What if the doors don't open? What if this crashes? I have no way out. Okay, that is when we say the claustrophobia. So it's not just a fear of riding in elevators. It's more or less I'm in this elevator, it closed. What if the doors don't open? What if I'm trapped? Something like that. And then you have something called nyctophobia, which is fear of the dark. A lot of people are extremely scareful of the dark. They can't sleep in the dark. They have to have lights on. They have to have some type of visualization when it's nighttime. As long as they have that, they're functionable. But let's say the lights were to go out, like in the case of a hurricane or an electricity blowout. If this person doesn't have immediate access to, let's say, a candle or flashlight, they may have an extreme panic reaction and they may have sort of what we call a breakdown. Okay. Hemophobia, fear of blood. Now, if you never heard of hemophobia before, this is one of those words where I say you can break it down. Okay. And you can possibly understand what the word means. So we already discussed what phobia means. Hemo is also another way for saying blood or hema. So if I was to separate the word hema, blood, phobia, fear of. Okay. Um, Acrophobia, fear of heights. That is not saying the same thing as fear of flying. That is another separate phobia. So this is just fear of heights. So this person might be scared of, let's say, going on roller coasters at the youth fair or wherever there's a ride because it goes so high up in the air. Okay. If they live in an apartment complex that has a lot of floors, they're not going to be staying on one of those upper floors. Okay, so staying in a high rise, probably not for this person. If they do stay in a high rise, they're on the lower part. Okay, and then there's a phobia called chlorophobia, fear of clowns. There are a lot of people that have a fear of clowns. One of the things that I've seen is that some of these people had a traumatic experience with a clown. Let's say it was at a birthday party when they were younger. So this could be something that happened in childhood that was never quite resolved. There's no other reason, wasn't that they was assaulted by a clown. It's just maybe the experience was a little too, fearful for them when they was little, and it just kind of carried over into adulthood. Now there are many, 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 many different phobias that are recognized by the ICD-10. Again, I'll find a link if you're just interested in seeing the different types, and they are categorized in alphabetical order. That is how many there are of them. These are just 1%, if that, of the different types of phobias that we have. So let's get into signs and symptoms. So these are the common manifestations of phobias. And there's different categories. You have your physical signs and symptoms, you have your emotional signs and symptoms, and you have your behavioral. So quick question for you guys. If I say that the physical signs and symptoms are objective data, what am I saying? Physical symptoms are objective. That means what?
And measurable data.
It is measurable. When something is objective, I, the practitioner, can measure it. I can physically see it. I can put a value to it. I do not have to rely on what the client says it is. So, with the physical symptoms of phobias, uh, I can see if a client is getting dizzy. One of the things I might do, I might check their blood pressure. So a lot of times when a person is dizzy or feeling lightheaded, we check their blood pressure to see if they're hypotensive. They may be trembling. So I notice the hands are trembling. You know, they might be biting their nails. Their heart rate, of course, will increase. They become tachycardic. They start sweating. If they are extremely sweating, I call that diaphoresis. Their breathing may change. So I'm noticing that they may be struggling to breathe. They may become nauseous, throw up, you know, vomit, or again, they may complain of chest pain. Now, the chest pain, that is something that I won't be able to see. However, if I was to measure their respiratory status, I might see that they are also tachypnic or their respiratory rate is elevated. Even oxygenation, they may struggle with. Now, emotional symptoms, those are subjective. So if I say a client is having subjective signs and symptoms of phobias, what am I saying? What type of data is subjective?
They're telling you how they feel.
Subjective is
Something
what
you
the
can
client
see,
says it
you
is.
can measure.
You cannot measure it. One of the biggest, most common subjective data is pain. We cannot put a finger on pain. You cannot define pain in terms of a physical symptom. It is just what the client reports it to be. So with the emotional symptoms of a phobia, this is just what the client is expressing that they feel. I have extreme anxiety when it comes to my phobia. I have a panic attack when it comes to my phobia. I feel like I can't breathe. I feel like the walls are closing in. I feel overwhelmed. This is the client reporting the degree of emotional responses that they have when it comes to their phobia. And then behavioral. Okay. Now, this is what the client physically does in relationship or in reaction to their phobia. So, avoidance is a huge thing. Now, some people might think avoiding is a good way to manage a phobia, but it's actually not, depending on the phobia itself. So, again, going back to agoraphobia, which is a fear of public open spaces, this might be a client that never wants to leave the home. Because they have such a fear of being in a space with other people, they're just going to stay home and just not go anywhere. That is not healthy. They are avoiding spaces with other people in it, which causes them to stay in their home. Okay. Some clients, they find it difficult to do basic functioning activities because of their phobia. Something like going to the grocery store, okay, going to work. Those are things that, you know, physiologically we have to do to survive. So if they have an extreme fear to something, it could keep them from operating as they normally would do. And then lastly, extreme measures to avoid whatever is triggering their phobia response. And when you say extreme measures, this could be something that is considered very drastic. Okay. And when we say drastic, it could be anything. There is something called a fear of water. Believe it or not, I can't think of the name right off the top of my head, but there are some people that have extreme phobias of water. One of the ways we see that symptom, people who develop what we call rabies. If you guys know what rabies kind of happens in sections. Most people, when they do display signs of rabies, unfortunately, it is very advanced and it's really very hard to treat them. But one of the most common signs of rabies when they're getting to the point of possible death, they have an extreme fear of water. There's a video that I saw when I was back in school of them trying to give someone with advanced stage of rabies a cup of water to drink. And you would
That's
have thought that
hydrophobia.
hydro, why that couldn't come to my mind? Hydrophobia. Couldn't think of that for nothing. Hydro, water, of course. They was trying to get a client something to drink, and you would have thought they was trying to pour fire down this person's mouth. He was fighting it, like he was so animated, and you probably like it's water, but in their mind, the phobia was so strong it triggered that type of a response. So these are your signs and symptoms that are associated with your different types of phobias. Now, how do we manage a phobia? Again, it totally depends on the type of phobia and the magnitude of the response. I don't know if you guys are familiar with the show Maury Povich, but it used to be really, really popular back in the day. And he used to do shows on people with phobias. And what he would do is, he would talk to the person and he would talk to them about the phobia. And they would then bring out whatever it was that the person was afraid of. Now, these weren't, things that you would think make sense for a person to be so afraid of. It was like very, very harmless objects. Like there was one lady who was fearful of cotton balls. That's a real thing. There was somebody who was fearful of like puppies or something like that. And I've also experienced a phobia in action, and we'll talk about it when we go over the therapy. Again, cognitive behavior therapy, trying to get a person to change the way they think or the way they view their phobias. Okay. If we maybe try to reprogram how they look at triggers, if you see this trigger, you don't necessarily have to have such an extreme animated response. Maybe as we work with you and you get around these triggers, you may, develop a little bit of fear, a little bit of anxiety, but hopefully over time, it does kind of go away. Exposure therapy, that could be also called desensitization therapy. Now, this is what I experienced when I did my mental health rotation back in school. So I did my clinicals, and before we got there, we were told that they were bringing a client in and they were starting desensitization therapy. I guess this was the second session, and the person had a fear of dogs. And this stemmed from a situation when they were younger. They had an extreme dog attack. They were injured. They were hospitalized. They had to have surgery. So understandable, that could lead to trauma. But this is something that happened in childhood. It followed this person into adulthood. And whenever they saw a dog, it wasn't like, oh, I'm scared. It was an extreme reaction to seeing a dog. So they were doing desensitization therapy. So when we were briefed on what was going on with the client, we were told that the client is going to go into a room and it's going to be an observation room. So we are going to be on one side of the room, and you guys probably seen those rooms with the windows where I can look in, but you can't look out. So it's one of those types of rooms. And the client was under the impression that they were going to be either looking at pictures of dogs or dogs on a video. And what the provider wanted to do is they wanted to give the client little tasks to complete while exposing them to the phobia. So it was like a puzzle with little pieces. It wasn't like a real hard puzzle. It was like a word search puzzle, a puzzle with pieces. It was like little tasks like that this person as an adult should have no problem completing. However, you threw in the phobia, so we were told that they were actually going to put puppies into the room at this point of the client's therapy. And I'm like, puppies? I'm like, who's scared of puppies? I'm like, oh my God, it's a puppy. Listen, when they when they put them dogs in the room, this client, listen, I can't even put into words. It was bad. He screamed, he jumped on the table. It was almost like he was almost gonna hurt himself trying to get away. And they're puppies. So they see him and they think he playing. So the puppies want to play. It was a mess. And that was my first real experience of what phobia response looks like. Now, to me, all I see is a cute puppy. And I'm like, oh my God, when he leaves, can I go in the room and play with the puppies? Like, that's what I'm thinking. But for that client, those puppies, even though they were small dogs, puppies, technically harmless, he didn't care. That puppy represented that big dog that bit him when he was a kid and sent him to the hospital. So with desensitization, the goal, hopefully, the more you are exposed to the phobia, the less severe your response comes. So for this client, obviously he was not ready for that. They probably set him back a little bit, putting those puppies into the room. But for him, maybe putting the dogs in the room wasn't quite the right thing to do. But again, it showed the level of response that he had to his phobia. And then hypnotherapy. Now listen, hypnotherapy is used for a lot. Okay. We use hypnotherapy to stop people from smoking. We use hypnotherapy to help people lose weight, to control appetite. We use hypnotherapy to try to reprogram thoughts. It also may be used to kind of get you to have a less severe response to the phobia. We get to the root of where your phobia comes from. If this is something that happened in childhood, I mean, how many of us really, really, really remember everything that happened when we was younger? So we might be able to get a little bit more insight to whatever's causing your phobia with hypnotherapy. And then we can offer suggestions to try to change the client's thought processes when it comes to the actual phobia. Medications, you've seen these before, antidepressants. Now, it's not so much to treat depression because we're not saying that a client that has a phobia has a depression. It might turn into depression because it is something that has been chronically affecting them. But in the beginning, there might not be a depression component with it. However, we do treat with antidepressants because we want to improve mood. The goal, maybe if the mood is improved, the phobia will have a less type of response. And then you have beta blockers. Now, beta blockers is not something you would typically think you will see is a medical, mental health treatment medication, but beta blockers kind of slow everything down. One of the things we talked about when a person has a phobia response, they become very, very elevated as far as the mood, the anxiety increases, the heart rate increases, the breathing increases, blood pressure may increase, everything kind of heightens. Beta blockers are known to reduce that fight or flight syndrome. You know, when you are faced with something danger, you automatically run. Okay, everything kicks into gear and you're going into survival mode. That is a lot of times what people experience when they're having their triggered response to their phobia. So with the beta blockers, the goal hopefully is to kind of just relax those symptoms, the tachycardia, the tachypnea, the elevated BP. So it kind of, lessens the heightened sensitivity that the client may have to that particular phobia. Any questions with treating phobias, whether it is psychotherapy, okay, or the medications that we use to treat the phobia?
I'm not really clear about the hypotherapy, please. Can
Say
you
that again.
I'm not really clear about the hypotherapy. Can you
Oh,
throw more
hypno.
light, please?
Okay, yes, no
Yeah.
problem, no problem. So what is hypnotherapy? So if you may have seen it before. So what a person, a trained professional does is they kind of put the person in a deep, relaxed state. Okay. They may CBT explain also. Okay, I'll do that also. No problem. Aquaphobia. That is what it is. Aquaphobia. Yeah, they're different interchangeable names for that as well. I'm just seeing that response. So hypnosis. So what the person does is they're going to put the client into a deep consciousness. It's not necessarily a deep sleep, but it's a very, very reduced state of consciousness. The person is asleep, but they're still impressionable, meaning there's still a way to get to the consciousness. They're just not actively alert or talking. So the way that they put this person into this deep state, they may use, let's say, a sound. You might hear like a ticking sound. I know everybody's seen the little watch that goes back and forward and they're telling you to focus, and then you hear you're getting sleepy, stuff like that. That is a way to relax the individual and put them in this deep conscious state. And once the person is under that deep conscious state, the licensed professional, they will start to make suggestions. Okay. If you ever seen those shows where they do the funny tricks with the people under hypnosis, they'll put them under into the deep, consciousness, and they'll tell them you're a dog. And then, they'll snap their fingers and the person wakes up and they start barking. It's almost like the power of suggestion. So with hypnotherapy, when it comes to a phobia, when the person is in that deep conscious state, the healthcare professional can make suggestions. Whenever you see this trigger, whatever triggers your phobia, whenever you see it, you're not going to act like this, or you're not going to do this. As a matter of fact, you're not even afraid of that trigger at all. Now, does hypnotherapy work 100%? No, it doesn't. Some people, unfortunately, they're not able to be hypnotized. That's another way to put it, hypnotized. Some people, for some reason, they're just not. It's almost like you have to have a certain type of a state of mind to see if hypnosis will work on you. But that is how we treat people with certain conditions. We just, it's just the power of suggestion. Okay. And then somebody asked me to go back over CBT. So cognitive behavior therapy. So again, cognitive is the same thing as saying cognition, and that is referring to how a person thinks, your cognitive processes. So for example, if there's a question, there may be more than one way to solve that question. One person cognitively will solve a question this way. One person, another way, will solve a question this way. One of the things we did with some kids, we gave them a math problem. And I'll give you a perfect example of how cognition works. We gave them like a simple math problem. And we said, tell us out loud how you would solve this simple math question. Okay. You know, most people, you add this, you carry this. Then there was a person, a kid that rounded all the numbers. Then they did the math and then they subtract the added numbers that they put to round it off. And I said, I never heard of that, but that is how that person brain worked. Okay, that was their thought process in solving the equation. So when it comes to cognitive behavior therapy, we want to take a look at how the person reacts to their phobia. When they are faced with the trigger, what do they do? What is going through their head? So once we understand that, we're trying to just reprogram how the person reacts, but we're doing it while they are awake and alert. Hypnosis, they're in that deep conscious state, and we try to reprogram how they think. With cognitive behavior therapy, the person is awake, the person is alert, the person is actually involved in making sure that their heightened response is less and less over time. So it's almost like just getting you to kind of rethink the way things are done. Okay. Again, when it comes to cognitive behavior therapy, it is not 100% effective. Sometimes you need to add components to it, like, for example, medications, but it does. We use cognitive behavior therapy with a lot of students, okay, especially kids when it comes to conditions like ADHD, autism, things like that, those neurocognitive disorders. We use a lot of CBT with those. And again, it's about focusing on the positive and less emphasis on the negative. So, nursing management for clients with phobias, very simple. Same thing like with PTSD. You want to make sure there's a calm, quiet environment for the client. Again, they could be, danger to themselves, endangerment to others. Actively listening. I might not understand your extreme fear of something. However, I'm going to actively listen. That is going to make you feel comfortable. I'm not going to make you feel like something is wrong with you for having this phobia. You have a real medical condition. I might not understand it, but I'm going to treat you with respect and compassion. I'm going to actively listen to you explain to me what it is that you're feeling. We want to make sure we know what triggers may potentially set the client off. Okay. While we are deciding on what therapy is the best route, we want to keep aware of what triggers the client's responses. And until we put the client on a clear path for recovery, hopefully, we want to try to avoid those triggers as best as we can. And again, each care plan is individualized. Nothing is one size fit all. We listen to the clients and we put together a plan of care based on what they say or they're feeling. Any questions with obsessive compulsive disorder? We're making great time. Okay, I'm sorry, any questions with phobias? So the last section we're going to go over is OCD. Very short, and we'll jump right into our NCLEX questions. So it is 10:20. We'll stay about 10 minutes. So it's 10:25. So
Somebody was asking on the chat the
oh,
difference between phobia and anxiety.
hold on. Let me see. Give me 1 second. I missed that. Normally it pops up that I have a message. I didn't see it. I see the difference between phobias and anxiety. So remember what I said. Phobias fall under the category of anxiety. Now, with anxiety could be a very generalized response. Okay. You just have a consistent feeling of nervousness, stress, it's just general. It's not nothing in particular. Or you have these extreme reactions to a lot of different triggers. With phobias, okay, it is usually something specific that is triggering these responses, these anxiety. And as long as you're not around that trigger, or as long as you're not aware of that trigger, you are probably functioning normally, or you are not having any interference with your daily life activities. But as soon as you are around that trigger, or you are reminded of that trigger, or whatever it is that you are afraid of, then the behaviors come. So anxiety is a very broad term. Phobias are more specific based on what the client is afraid of. Does that make sense? Hopefully. Thank you. So 10:25, let's take a 10-minute breather. We will finish OCD and then we'll jump right into our practice NCLEX questions. So 10:35, we'll be back. Okay, everyone, let's get back into it. We're going to finish OCD and then we're going to get right into our NCLEX practice questions. So let me get into, are you guys still able to see my screen? Just want to make sure.
We
I
only
don't.
see you.
Okay, perfect. Thank you. Yeah, thank you. So let me see. Sharing is not turned on. I am not able to share what is going on with this. Give me a second, you guys. I'll see if I can fix this.
Go through the participants and see if you can reclaim the host.
Let me see. Am I able? I am. Listen. Who is that? Who is that?
That's me.
Who is
Yes.
me?
Oh,
Me, what's your name?
my name is Wilson Chaz.
Listen, you need to just be my IT person, okay?
Oh, all right. So why you pay me so much money?
Because listen,
Oh my God.
am the least techie person on the planet, okay? It would have took me forever to figure that out. I have no idea what that was, what that means, but I learned something. Thank you so much.
You're
So
welcome.
OCD, let's get into it. Let's finish this so we can finish our NCLEX questions. So OCD, obsessive compulsive disorder. So this is again a type of anxiety condition, persistent intrusive thoughts, repetitive behaviors, compulsion. So those are the three main components of OCD. Again, intrusive thoughts that are persistent, obsessions with rituals is what we call them, and compulsion. So it's almost as if whatever the repetitive action is, the person has to do it. They are compelled to do it. It's like an urge to do it. And for them, it's probably something that makes them feel safe. It could be, again, a reaction to anxiety or stress. However, this can interfere with daily activities if it becomes more of an obsession in terms of they can't do anything until they perform their rituals. For a lot of these clients, they are aware that they do have OCD, and for them, they do not want to have these behaviors. They don't want to do these realistic type again, something like washing your hands 50 million times a day. Before you can go to bed, you got to check to make sure the door is locked. You just checked it 5 minutes ago, but you're saying to yourself, was it really locked? I'm not sure. Let me go back. Or you have to do something before you walk out the door, like knock on the door 3 times and then walk out of it. For these clients, if they don't do that particular activity in that particular way, it can kind of mess with their thought processes for the entire day. Again, these people are aware that they have this condition, and these are just unwanted type behaviors. So these are the characteristics of OCD. Okay, so main manifestations or main characteristics: obsession versus compulsion. So obsession is persistent thoughts that are unwanted. Okay, this persistence of thoughts causes extreme anxiety and extreme stress reactions. Okay, fear of contamination. Now, nurses, we wash our hands a lot, but we wash our hands because we understand in between patients, we're supposed to wash our hands. If we get something on our hands, we're supposed to wash our hands. However, for these individuals, they don't necessarily have to be doing anything that causes them to have to wash their hands so much. But for them, it is something that helps with their anxiety if they do wash their hands multiple times a day. Fear of being harmed, worrying about something that is not symmetrical. You have some people when they hang a picture, The compulsion is for so the compulsion is supposed to help calm the client, but it has like a double-edged sword reaction. On one hand, they don't rest the mind until they complete the action and they're compelled to do it. But on the other hand, it becomes so overwhelming because they are aware that how they're feeling is not natural and that how they're feeling is taking over daily life activity. So it's almost like a double-edged sword. Okay. With the compulsion, again, they are compelled to do it. It's like they have no choice. It's almost like a reflex. That's a great way to put it. When you have a reflex response, your body does it without thinking. So for them, it's almost like they have to do it, and there's no way for them to stop. If they don't perform the action, they will have extreme reactions of anxiety and stress. So it's almost like we kind of let them do the behavior to keep them calm as we figure out how to help these clients. So there is a cycle when it comes to OCD, obsessive compulsive disorder. It starts with the distress. Okay. Um, it could start with the obsession. So actually, you know what, I'll start there because that's for some people, it really starts with the obsession. So there's something that you are obsessed over. It doesn't matter if it's, a thought process. It doesn't matter if it's a ritual. So again, washing hands, knocking on the door 3 times before you walk through it. Those are called rituals, things that people have to do. And what happens is they become distressed behind the obsession. It's almost as if they don't do whatever they have to do, their rituals, they become stressed out, they become anxious, it's hard to function, it may be hard to sleep, and so forth. Then they have the compulsion to do it. It's like, now I have to. It's not a matter of should I do it or not. It's like I have to do it, or my condition, my feelings, the way my anxiety, my stress levels, it is going to elevate. And when they do the ritual or perform the act, they feel an instant relief. But this relief is temporary because, again, they are aware they have OCD, and it is just the repetitiveness of having to continuously perform these actions. It gets tiring. And it also can make the client depressive because, again, they feel like they're trapped within this disorder because they feel like they have to do these things. So there are related disorders to OCD. So some clients just have OCD by themselves, and then they have related disorders. Hoarding is a form of OCD. And if you guys ever saw that show on, I think it's AME, Hoarders, and it's not just, I have trouble throwing away old clothes. This is like hoarding is like you're just holding on to a bunch of stuff, even if you don't even need it. Okay. This could be something that broke a long time ago. It's not even useful anymore. It doesn't work, but you can't seem to part with it. People who are hoarders, it is not just, you got a lot of stuff in here. It's almost like it is cluttered. It is everywhere. There's possibly no organization. It is just stuff piled on top of stuff. Okay, that is a mental health disorder. If you've ever seen the show Hoarders, they go through the process of helping those people recover. Body dysmorphic disorder. So this is an obsession with the body. However, the image that the person sees is not realistic. You can see this a lot in people who may have something about themselves that they don't really like, or they, attribute something negative to their bodies, their face, their body shapes, things like that. I see this a lot in young girls that are, practicing anorexia. When they look in the mirror, they feel like they're overweight. But when I see them, I see a person that is either normal, BMI sized, or they are severely underweight because they are not eating on purpose. Okay. Excoriation. This is when a person repeatedly picks at their skin. It could be that it's just a nervous habit. It could be an anxiety response. You have some clients that feel like something's crawling on their skin and they pick at their skin so much they start to bleed because they break the skin. And then you have body focused repetitive behaviors. So this is something like somebody that bites their nails a lot. You have some people, they're always like, shaking their legs, or, they're doing this on the table. It's almost like your body has to be repetitively in motion. And if you don't perform these activities, again, you become very anxious and you become very distressed. Now, when it comes to managing OCD, we treat it like we treat all the other disorders. Again, psychotherapy, and again, the medications, the antidepressants, the anti-anxiety medications. But when it comes to managing OCD, a lot of times you don't even need the medications or the therapy. Sometimes we just have to allow the client space to perform the activity. Sometimes the OCD is something very minor. It's not to the point to whereas it's very disruptive. It's just that the client has to perform these rituals so that they can go on about their day. So we are providing a safe, low stress environment. We're also giving the client an opportunity to perform their ritual so that they can calm down and they can, maybe get further help if needed. We want to have empathy and you want to be patient. You might not understand the OCD, but again, validating the client that what they're feeling is not imagined, made up in their heads, that helps them to process what they're feeling. Encourage communication, encourage the client to express what they feel. Sometimes we don't know how to help a client when it comes to mental health disorders. We only have what the client tells us that they are feeling. We want to talk about treating, sometimes therapy in terms of talking. Okay, we may need to put the client on a medication if there's a comorbid existing condition such as depression. Some clients do become depressed when they are diagnosed with OCD, hoarders, and things like that. Boundaries are very important when it comes to dealing with mental health clients, especially clients with anxiety disorders. It is very important to set boundaries. Okay, we set the boundaries so that the behaviors, the ritualism doesn't overtake or overpower the client. See a question. Now, that is a great question. If the ritual is harmful, of course, we do not allow the client to perform it. Instead, we will try to redirect the behavior. That is the best that we can do. We cannot allow you to complete a ritualistic behavior where you're self-harming or possibly could harm somebody else. Absolutely not. Okay. But if I have a client that has to put something in a certain order on a table, the books have to be a certain way, something like that, you know what? Just go ahead and, fix it up, and then we can get back to whatever we was doing. Encourage socialization. Sometimes people who have OCD, they are loners. They don't socialize, they don't go out. If they become more sociable, that may kind of help with the OCD symptoms, because some people have anxiety again when it comes to public places, and that could trigger their OCD type responses. And again, the distraction techniques. So if we have some person that is again performing something that is a danger to themselves or possibly danger others, we will try to distract them. Now, depending on the severity of the OCD, the distraction may not be enough, and we have to take more drastic measures. Like, for example, and this is a last resort for me, but restraining. Okay. And if you guys remember how that works, if it is an emergency situation, you can restrain a client without an actual physician order. But as soon as the client is stable, you need to call the doctor, inform them what is happening, and you need to get a verbal order, and you recheck the client within about an hour or two. Any questions with OCD? Told you guys that was going to be very, very, very quick. Now, let's go ahead and knock out our NCLEX questions. So what I want you guys to do, now I definitely want you guys to get involved. Okay, type your answers into the chat. You can always unmute yourself and answer the questions. You want to discuss the questions, we can do all of that. Okay, so I am sharing my screen again. There. Oh, are these the questions? They are. Okay, so let's get into slideshow view, and we will start with question. Let's go ahead and start with question number 1. So again, I am looking into the chat to see you guys' answers. So question number 1, The nurse determines that a client is at risk for post-traumatic stress disorder and teaches the client to recognize symptoms of PTSD. Which symptoms does the nurse include? So this is basically if I'm explaining or teaching a client about symptoms of post-traumatic stress disorder, what would I teach the client that they may experience or they may feel? So this is a select all that apply question. You have reoccurrent intrusive recollections or thoughts, increased involvement in goal-directed activities, sleep disturbances, flight of ideas, and lastly, difficulty concentrating.
I think A, C, D, E, if I'm
I
right.
see C, D, E. I see A,
A,
C.
C, E.
A,
Okay.
C, D, E.
Okay, A, C, D, E. I see a lot of you guys are picking the same answers. Okay, so the correct answers are A, C, E. Very, very, very good. So some people included D. Most of you did put A, C, E, but some people included D. So I'm going to go back to the previous slide. Flight of ideas. So you would think that that is a component of post-traumatic stress disorder, but it's actually not. Okay. So when it comes to flight of ideas, okay, that is more seen in bipolar type disorders. So manic type disorders where a person is kind of up and down. You know, when you say flight of ideas, it's basically like a bunch of things that's going through your mind all at one time. They may not even be related to each other, but you're kind of just all over the place. That is not typically seen with post-traumatic stress. Remember, post-traumatic stress could be linked to one particular traumatic event versus bipolarism. You know, it comes and it goes. The mood is up, the mood is down. And when the mood is up, the person is kind of all over the place. Okay.
Can I say the question one more time,
You
please?
surely can see the question one more time. Okay, so it's a basic education question. So you are, so the client is at risk. So it's not saying the client has PTSD. The client is at risk for possibly experiencing PTSD, and awareness is something that helps when it comes to mental health disorders. Being that a lot of it is what the client says that they feel, it is important for the client to be aware of what symptoms they may feel if they are developing certain disorders. So this is just about making the client aware of those symptoms typically associated with PTSD. Question number 2. A client diagnosed with agoraphobia, fear of becoming overwhelmed or unable to escape or get help, who experiences panic attacks is talking with a nurse about the progress made in treatment. Which client statement indicates a positive response to treatment? Now, with this type of question, okay, this is an evaluation question. So much we think about assessing and what interventions do we do. We don't think about we have to evaluate the effectiveness of what it is that we do. So how do I know my interventions are working? That is this type of question. If I give a
A.
client a pain medication, how do I know the pain medication is working? I see a lot of A's, and it seems like everybody, I see a B.
I think it's
Okay, I see A's majority. The answer is A. So again, agoraphobia is a condition where your fear of being in a space and your fear something might happen and you can't get help. So typically those are places where there's a lot of people. You know, you go to a place, there's only one exit, and you're afraid that if something was to happen, you won't be able to get out into that exit. So for this person, okay, they may be socially withdrawn because they have this fear. They're staying home. They're not venturing out. So one way to notice that the client is improving, listen, I went out. And when I say I went out, I didn't just walk to the mailbox and walk back. I literally went somewhere where there was other people around. I was nervous, I was scared, but I was able to do it. That is the first step. Then we work on, reducing the anxiety, stressful responses when you are around your triggers. Question number 3. A psychiatric nurse is caring for a veteran who is dealing with post-traumatic stress disorder related to their time serving in an active war zone. Which tool would the nurse prioritize for this client. So when we say tool, we're talking about the plan of care. Okay. Now keep in mind with this type of question, when you are asked to
It's
prioritize
A.
something, it's A. Okay, let me see. You are fast. Let me see who else in this chat.
Why not D? Why not D?
Why not D? That's a great question.
I like A and D.
You like D. Okay, so quickly, the answer is actually A.
A.
So let me go back.
Which is the priority.
So that is exactly. Now, keep in mind with priority questions, okay, they are not saying that the other options are not important. They are not saying that you won't do the other options. They are basically asking out of these options, what is the
One is a
very
safe
first
one.
thing
Mhm.
that you need to take care of? What is the priority over everything else? Everything else will get addressed, but this is the first thing that I need to address. This client made a statement. Okay. They could have made a statement. They could have, whenever they hear a loud sound, they're triggered. So this client has post-traumatic stress. And because they were in an active war zone, for those who have served in the military, there's a sense of danger, there's a sense that something, terrible can happen. So even though the client is no longer in that environment, they are still dealing with the memories of that environment. So because they have that heightened sense, they could possibly endanger themselves or someone else, whether it is intentional or not. The reaction could cause them to possibly harm themselves. So safety is always a priority when it comes to mental health disorders, creating a safe space. If the client displays these behaviors, what can I quickly do to calm them down? Do I need to remove them? Do I have somewhere for them to go? Can I give them something? That is how you prioritize safety, and it is client specific. Okay. Again, all the other options, that is something you're going to take care of at a later time. It's just not the priority in this situation. Question number 4, a nurse is caring for a client with OCD. Rituals of washing hands, folding and unfolding towels, and switching the bathroom light on and off multiple times prior to meals. What action should the nurse take? Now, remember, when it comes to rituals associated with OCD, in a lot of cases, this is done to calm the client down. It's not like they have a ritual that is harmful to themselves or to someone else. And
C.
maybe it's just something that, they need to do so that they can function appropriately. Okay. I see some A's, I see some D's, I see a lot of C's. Okay. So for this question, the correct answer is D. Okay, so here is the rationale. Again, not saying all the other stuff was wrong. What we know is when it comes to rituals, okay, it could be not just obsessive, but it can be time consuming. If the goal of care is to eventually get the client to stop the obsessive compelling behaviors, at some point I need to gradually over time decrease their ability to perform that. Yes, a permanent a lot. Yes, can make dermatitis. That could be a way that I can desensitize them to yes, you need a reduction in the behavior. If we continue, even though we said in some instances we may allow you to perform the behavior, it's just that at some point we have to focus on, okay, we have to limit this behavior. We have to try to put a cap on this behavior. So if in the beginning, if I allow time for you to do it, over time, listen, you got 10 minutes and I have to set boundaries. Before I may have gave you 15 minutes to get ready for dinner, but now we are down to 10 minutes. Okay. I'm not stopping the client cold turkey from performing their ritual. I'm just limiting the time that they have to do it, and I'm setting boundaries. 10 minutes, you need to be at the table. And then sooner or later, it's going to go down to 9 minutes, 8 minutes, until hopefully the client is no longer performing that activity or that ritual. Question 5, the nurse reviews client messages received in the community health clinic. Which client should the nurse make a priority? Again, when it comes to priority questions, you are not saying the other options are not important. You are simply saying that this is a client that I need to take care of before all the others. Okay, that is what that means. And let me see what I got. Okay, I see a lot of B's, 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 B's. Of course, the answer is B. You have a client with post-traumatic stress disorder. They wish that they were unalived. That is somebody that I need to make a priority. They are having what we call suicidal ideations. Okay. And clients with post-traumatic stress disorder, sometimes they also have depression. So if we're treating not just the post-traumatic stress disorder, we're also treating the depression with antidepressants. There may come a time where the client may try to follow through with their wishes. They have the suicidal ideations and they are at risk for going through with them. So everybody else, of course, I'm going to address their concerns, their needs, but the client that's having suicidal ideations, that is my extreme right away, get back to priority. Question 6. A nurse is caring for a client diagnosed with claustrophobia, fear of being enclosed or in confined spaces. Which signs and symptoms would the nurse anticipate? So, client with claustrophobia, fear of being in enclosed or confined spaces. If I have a client with that particular condition, what signs and symptoms or manifestations would I expect to see? Okay, this is select all that apply. So I see ABEs, AEs.
ABE. ABE.
Okay, it's about everybody about the same. So answers are A, B, E. Great job. So remember, claustrophobia, intense fear of enclosed spaces. Imagine getting on an elevator, the door closes, and you are confined and you are afraid that there's no way to get out. It's like, I'm feeling like I'm suffocated. So going back to the answer options, feeling of doom. I'm in this enclosed space. I can't get out. I feel like something's going to happen. My panic attacks may start. I'm in this confined space. I start picking up the breathing, hyperventilating. And E, feeling stressed when in a tight space. So that is the literal definition of claustrophobia. Hallucinations and insomnia, that is not directly or typically associated with the condition known as claustrophobia. Question 7, client diagnosed with agoraphobia. Again, fear of becoming overwhelmed or unable to escape or get help. Refuses to walk down the hall to a group room. Which response by the nurse is most appropriate? So you have a client that is afraid that if they walk to the group room, that they may be enclosed. So they're not in a tight space, but they may feel like if something happens, they can't get away, they can't get help. I see a lot of D's. I do see a C. So which response is appropriate? So which response is therapeutic? Remember, the issue is the client is refusing to walk to group. They have to go to group. They have to walk. That's the only way that they're going to get there. We're not going to carry you. You're going to have to walk. So how do I facilitate that happening? The answer is D. Listen, I'll walk with you. I'm not going to make you walk by yourself. I'm going to help you stay safe. Okay, that is how we support the client. That is how we validate their feelings. You don't say, listen, nothing's going to happen. You're going to be good. Group is right there. Let's go. That is inappropriate. That's not therapeutic. Me saying, I'm going to walk with you, that validates the client's feelings. That is, again, creating a safe therapeutic space for the client to exist in. Okay, if I excuse the client from group every time they feel that way, they are never going to complete treatment. Okay, so that is why those answers are incorrect. Question number 8, a client comes to the mental health clinic with suspected obsessive compulsive disorder. The client explains that the compulsion to wash hands is interfering with employment. Which interventions are appropriate when caring for a client with OCD? So the background history, client excessive compulsive washing hands throughout the day. It is interfering with their employment. What interventions are appropriate to help this client that must wash their hands multiple times a day? That's probably a nurse. Let's see. Questions. I see. I see CDEs, BCDs. Okay, round is pretty much the same across the board. The correct answer is, and you guys pretty much hit it on the nail, BDEs. I did see a C here and there. So going back to the question, so you guys can see the answer options. So what is appropriate for this client that is obsessed with washing their hands multiple times a day? Okay. Do not allow client time to carry out the ritualistic behavior. Now, we did say we will give them time to do their rituals. However, over the course of treatment, we're going to allow them less and less times. If you stop the client cold turkey from doing rituals, that can have an adverse effect. Okay. Support the use of appropriate defense mechanisms. Again, when you feel the compulsion to wash your hands, let's try some deep breathing exercises. Okay. Or let's try some distraction. Close your eyes and think of something that relaxes you. Encourage the client to suppress. No, we never encourage suppression of feelings. Remember, we validate, we acknowledge, we have compassion, we have patience. Okay. Explore the patterns leading to the compulsive behavior. That is definitely an answer option, because what is triggering you to excessively have to wash your hands multiple times a day? And lastly, listen attentively, but do not offer feedback. Sometimes active listening or just quiet listening also works. We say a lot of active listening where you are actively responding to the client that's talking to you, but sometimes the client just needs to vent. Okay, and they need somebody to vent to, and sometimes just sitting there with the client while they vent, that can be therapeutic. Okay. Question 9. A client is diagnosed with arachnophobia, fear of spiders. Which type of therapy would the nurse most likely expect to see included in the plan of care? So this client has an extreme reaction whenever they see a spider. Now, not saying none of these options are the answer. What the question is asking you, most likely, what might I see the doctor order for this client based on these types of therapies? And we will talk about them when we answer them. So I see some A's, I see C's.
I think
Let's see.
A.
A and C, back and forth. Okay, looks like you guys are back and forth. So the correct answer, C. And I think majority did put C. So behavioral therapy. Okay. Now, CBT, cognitive behavior therapy, that's usually one of the first options when it comes to managing phobias. Um, Again, this is to try to get the client to change the way they think about spiders. What if the client thinks that every spider is poisonous? Every spider is poisonous. Every spider gonna bite them. They're going to get sick, so forth, so forth. So that's why, regardless of the type of spider, the client sees one, they are definitely afraid. They become distressed. What we have to do is have to try to change the client. Yes, there are some spiders that are deadly. We're not saying that. But not every spider that you're going to come in contact with is deadly, is going to bite you. So it's almost like we're just trying to change your perception of spiders. Okay. Now, yes, a tarantula is dangerous, but usually we don't see tarantulas running around our house. We see those little small, little harmless, tiny little spiders. So that is what the CBT does. It kind of gets the client to kind of, redirect their thinking or change how they view what is causing them that fear and that anxiety. Last question, number 10. A nurse discovers that a client with obsessive compulsive disorder is attempting to resist the compulsion. Based on this finding, the nurse should assess the client for. So, with OCD, we know that the client is compelled or obsessed with doing their rituals. However, if the client tries to not do their ritual, what might they display if they aren't allowed, or they're preventing their own self, or they're trying to fight the compulsion to perform the ritualistic behavior? What response, what we might see from this client? I see a lot of C's. I see a lot of A's. Oh, this is good. This is a bit mixed. I see a D. Okay, so there's a mixture of answers. The correct answer is actually D. Now remember, we allow
Causes
clients,
anxiety.
We allow the client time to perform their ritualistic behavior. It kind of eases their anxiety. Just that over time, we're going to again slow down the access to be able to do the ritual with the hopes of stopping it altogether at some point. Okay, you may see the other responses, however, with the exact direction or the exactly related to not being able to do the ritual, that may cause feeling of anxiety and stress.
Excuse me, Professor.
Yes.
So when is the video of today's lecture going to be online?
I'm not really sure. I know that it is recorded and it is saved in a database. And one of the IT or one of the supports is going to upload it. If you have any questions, there is a section where you're able to send questions and inquiries. I'm not exactly sure where the videos are saved to, and I do not want to mistakenly tell you anything that is not correct. Okay. But there is a contact support option that you have, and I would definitely reach out to them so they can tell you the exact location of where the recording will be. Now, before everyone goes, in the chat, I have posted a link. This is where you guys can fill out a questionnaire about the webinar. Feel free, leave your thoughts, exactly. I love positive criticism. There's always room for improvement. Anything more you would like to see, anything less you would like to see, please leave the review. I would totally appreciate it.
I'm sorry for cutting you, Prof. To the last question, please. If the patient is resisting the compulsive behavior and start having increased anxiety, so then what do we do as a nurse
Okay, that's
when
a
these
great
patients
question.
start having increased anxiety?
Okay, so that's a great question. What do you do as a nurse when a client is experiencing anxiety? Now, we know that goodbye, you guys. Thank you. You are free to go. So if anybody has any questions, you can stay behind. We can have a discussion. But thank you guys for joining. I will see you next week for adult health if you are joining. So with the anxiety, your goal is to remember, prioritize safety, because we don't know if the anxiety will have an extreme reaction and a client may potentially hurt themselves or hurt someone else. So your first priority is make sure the client is safe. Secondly, you will provide them the space and opportunity to perform the ritual as long as it is not harmful to anyone or themselves. Remember, performing the ritual will help to calm the anxiety. They get the anxiety from not being able to perform their ritual. Even if it's something harmless, if they don't do it, they are obsessed with the idea. They have to do it. Like, I can't do anything else until I do my ritual. So because we know that it calms down their anxiety, that is how we first address it. Allow the client to perform the ritual. However, over time, you are going to limit their ability to perform the ritual. If I just continuously allow the client as much time as they need or as much time as they want, we're never going to reach to the point to where as we can possibly stop the behavior altogether. So you would allow the client to perform their ritual. If that is going to help with the anxiety at the present moment, again, as long as they are not in harm's way or no one else in harm's way. You guys are welcome. Thank you so much. So that is how it's like a double-edged sword. We want to stop the behaviors, but we don't stop it cold turkey. It's like smoking. Some people, they are addicted to smoking and it is very hard to stop. Like, tomorrow I'm done. Instead, what we do is the treatment kind of weans you off the nicotine, because that is what is addictive. It's the same concept with OCD. We're going to try to wean you off these ritualistic behaviors that you must do. We're going to allow you to do it, but little over time, you're going to allow less time for the client to be able to do these activities or these rituals.
Okay, Prof. Thank you so much.
You're so welcome. Any other questions?
Professor, about this next class, I see people saying 8 and 9 route. You know what is that? Like RAT 8 and 9?
Oh, I think that is the readiness assessment test, if I'm not mistaken.
Oh.
RAT, readiness assessment. I think that's like a test you do to see your readiness for the NCLEX. I could be wrong.
Yeah, I see the red name, but the 8 and 9, I don't know if they want. I mean,
It's number 8 and number 9 readiness
Oh,
assessment.
it may
I
be
was a
the number
coconut.
of the test. Is that the number of the test?
Yes, the number, because they have like a 1 readiness assessment, number
You
2,
know,
number
so
3,
that's
and so far.
So that must be what that is. The tests are just numbered, or they may have an order of succession that they want you to do those tests.
because
But again,
everybody's talking about 8 and the 9 trials. I was like, what is is it the readiness A number 9 and 8 and 9?
could be
Yes,
again,
it's
I'm
the
not 100%
readiness
sure.
Just
assessment,
do the
8 and
assessment
So
9.
much,
only.
I'm gonna leave.
No problem.
Before you
Have a nice
before
night.
you write your exam,
Thank
try
you.
and
Bye.
do readiness
Excuse
8
me.
and 9.
Oh, okay.
Just do the assessment only, and that's it. That's why
Okay.
they say.
Oh, okay. Okay.
So your question was answered. You good?
Who is a reclaim host and who is a stay participant?
I'm not sure. Let me see, Jay. You know, like I said, y'all know I am so not techie at all. We still have some people here. I guess, oh, I'm still the host. It's still me. But there's about what? How many people are still here? 30 something people here. We're finished. You guys are free to go. If you would like to know where the presentation will be uploaded, you can always contact support. Thank you so much, Andres. You can always contact support so they can specifically tell you specifically where the presentation will be uploaded, because unfortunately, I'm not 100% sure where that goes, but you will have access to the recording at some point.
Thank you, Prof.
Can you
Have a good
tell
night.
us the question where the answer was CBT therapy?
Cognitive behavior. So remember with CBT, that is usually one of the first therapeutic plan of cares that we implement, because remember, CBT is just basically trying to get the client to, redirect how they think. A lot of times there are negative thoughts associated with a lot of mental health disorders, a lot of triggers. So with CBT, which is cognitive behavior therapy, you're welcome. With CBT, all you're simply doing is you're validating that the client does have these feelings, these thoughts. However, you're just trying to change the way that the client views them, or you change the way the client thinks about them. You want to put emphasis on behaviors or actions that are good and positive. Like if a client does something, that is not negative in terms of whatever it is that causes them the anxiety, do more of that. Okay. Instead of when I'm triggered, I have a panic attack. When I'm triggered, I do deep breathing exercises. And that is something I want to encourage you to do more of. I want to encourage less panic, more deep breathing, more relaxation techniques. So that is how we do cognitive behavior therapy. We just try to change the way that the client views certain things. And if it is successful, hopefully the goal is whatever the mental health disorder that the client has, such as an anxiety, OCD, PTSD, phobias, the response will not be as severe as it once was. It's almost like effective coping. We give the clients the tools to be able to effectively cope, because sometimes you can't cure a mental health disorder. It's not like, again, you could take an antibiotic and you're good in a couple of days. It might be something lifelong, but we want the client to be able to manage, be functionable in their daily life, something like that.
Thank you.
You're welcome. Any other questions? You guys ask great questions. I love it. Okay, well, if there's no other questions, I'm going to conclude the meeting, and I will see you guys hopefully next week. I am covering some adult health concepts Wednesday. You guys can take a look on the 9th, I believe that is the next Wednesday, and I'll see you guys next Wednesday, hopefully. You guys have a great, great, great night.
Thank you, Prof. Good night.
Good night. You're welcome.
Thank you.
Bye.
Bye.